So we were talking about the general sensations, and we talked about tactile receptors, baroreceptors, proprioceptors. This slide is important. So pay attention to this. Tactile is coming from tactation, which is touch. Tactile, tactation, touch. Okay? Is touch is just touch? No, you can touch, right? And not just touching, you can push, right? It's a deeper touch. So this is considered pressure. Or you can get that vibrator and touch. They'll give you the vibration. So with the same one, you can get three different types of sensations with the tactile receptors. Touch is one thing. Deeper touch is considered pressure. To touch, pressure, vibration. These are the three things. Baroreceptors, these are very important. Basically, it detects that pressure within a hollow organ. Pressure within a hollow organ. If you put pressure in an artery, if you put pressure in the bladder, in the intestine, any hollow organ, and you started to distend the wall, this is considered pressure, baroreceptors. Baroreceptors. Baro, translation, pressure. Okay? So baroreceptors are different than tactile pressure receptors. Both of them are pressure. Yes. Did you get it? Both of them are pressures. I understand. But pressure like this, touch and push, is something, and pressure on the wall is something else. The pressure on the wall is baroreceptors. And the most important of those are within any hollow organ. When you distend, like if you put half a liter in the bladder, and then the more you add, the more it distends, right? The pressure is increasing. If this is an artery and there's blood inside, the blood is exerting a pressure on the walls, right? The more blood or the more pressure, the more extension, this is baroreceptors. Proprioceptors are those unique receptors in the joints and skeletal muscles. We talked about it before, and it is basically for position. It detects the position and the joint movements. Position and joint movements. And balance too. Yes, it helps in the balance. Okay, there are two types of touch and pressure. Fine touch, fine pressure, crude touch, crude pressure. Just understand the meaning. Fine touch and fine pressure is like this. Like you get something that's tiny, like a piece of cotton or something, and just touch. This is called fine touch. Fine pressure is just a pressure in one spot and you're not pushing much. This will have a narrow receptive field. And what does that mean? What does it mean if you have a narrow receptive field? You're watching this area only. It's more accurate and more sensitive, right? Do you remember that from the beginning? If I'm watching this area only, I'm watching both of them, and anything that they do, I can just detect it because I'm focusing on this. But if you give me a larger receptive area, I'm watching the whole class, maybe I'm looking here and something will happen there. It's less sensitive, less accurate, which is the crude touch and crude pressure. Larger receptive area, and it's less accurate, less sensitive. What are these tactile receptors? Free nerve ending. This is one for touch and pressure. This is how it looks like. Root hair plexus. You know the hair, we talked about the hair. Remember the root? Around the root, there are nerve endings or receptors. And these are going to monitor the movement of the hair. And if you like pull out the hair, you will feel pain, right? Because you're pulling it out from the roots. There are receptors there. Root hair plexus, like this. This plexus around the root. Tactile disc, fine touch and pressure. Raphenocorpuscles or bulbous corpuscles. Just the names is enough here. Lamellar corpuscles, Pacinian corpuscles is the same thing. This is for deep touch. What I'm telling you is enough. Okay? Lamellar corpuscles or Pacinian corpuscles, deep touch. And this is fastly adapting. That's it. This is how it looks like, which is not the most important thing. Tactile corpuscles, also known as Meissner's corpuscles. And this is more in the areas that does not have hair, hairless, you name it. You know what's exactly in your body that doesn't have hair, like your lips, your fingertips, and so on. Anything that does not have hair. Good enough to know. Baroreceptors. This is what I talked about. Baroreceptors are not the same as tactile pressure receptors, right? Baroreceptors, hollow organs. Okay? Hollow organ like what? I think we know our body, right? Artery is a hollow organ. Digestive system is a hollow organ. Urinary system, bladder, urethra, ureters, anything that's hollow organ will have the baroreceptors. But some of them are more important than the rest. And I will be talking about this. So there are receptors all over the place. Baroreceptors, one of them are located in the carotid sinus and the aortic sinus, and these are the most important ones. What does that mean? Do you remember the heart? The aorta come from the heart. Do you remember this? From the aorta, these are carotid arteries. So there are these baroreceptors around the aorta itself and around the carotid coming from the aorta. Specifically when it splits into external and internal carotid. Do you remember the internal carotid going to the brain? Yes, with the point where it bifurcates or divides, this is where carotid baroreceptors are located. The other ones are around the aorta. So if you look at this picture right here, you should be able to see that. Do you see this? This loop right here. This is the aorta. So it's located here. And then if you look at this coming up here in the neck, this is the carotid. At this point where it splits, this is the other ones. And this obviously detect blood pressure. Detecting blood pressure. So how does it work? If the blood pressure increase in this area, you're going to distend the wall, right? These receptors will be stimulated. It will send that signal to the brain stem. Do you remember the brain stem when I told you this is what you need to know about the midbrain and pons and medulla oblongata? It will send it to the medulla oblongata, telling the brain stem the pressure is going up. So the brain stem will send the signal to the heart, slow down, dropping the pressure down. Did you get the idea? That's how simple it is. What if the blood pressure drops? Yes, these receptors are not stimulated. No stimulus go to the brain stem. So the brain stem will not tell the heart to accelerate, so the blood pressure will go up. So it's kind of negative feedback. Do you remember this? This is one of the negative feedback. But specifically, how does it work? Distending the walls. When the blood pressure increased, distending the wall. And these are stimulated. We have it simply everywhere else. And this is we don't have to go through the details. Just understand the lung expand. It's a hollow organ. Yes. Digestive system, the digestive tract, I mean. Yes. Colon. Yes. Bladder. Yes. Bladder specifically would be the second important one. But the most important is baroreceptors in the carotid sinus and aortic sinus, followed by bladder wall. Otherwise, you can just say any hollow organ. Proprioceptors, just understand that this is the one that's responsible for position and posture, right? And where is it? Joint and muscles, right? This is what I want you to know. The other thing is that you need to know is that you have it in the joints, but do I have it in the viscera? No. What do I mean? Do you know where is your liver? Can you, like, I know my joint, for example. Like this is I'm closing my eyes. This is my elbow joint. It's flexed, it's extended. I know, right? Can you tell me where is your liver? Right? Unless you studied and you have an idea. But can you tell me where is it? Why you don't know about it? because there are no proprioceptors in the viscera. Okay? Just to make it more clear, I will tell you a scenario that actually happened to me when I was in the medical school. I have this patient, and we're supposed to write like a report on that patient. So I was like doing the normal stuff like examination and auscultation, and I'm hearing, and I couldn't hear much. And I was like really worried that I will not be able to do the report for that patient. And until the patient actually, chronic patients, they know what they have. So the patient was saying like dextrocardia. Dextrocardia. What? The patient. Yes. So I talked to the professor, and I told him like I'm trying to do like the normal. There are points. Every point is for one of the valves. So I told him that I'm trying. He told me like think about it. Maybe there is like something different in this patient. I figured it out. It's dextrocardia. So it turned out to be he's having dextrocardia, which is basically his organs are mirror imaged. Everything you imagine is the opposite. Like here is the heart, no, it's like this. Okay, this is the stomach, no, it's here. This is the liver, no, it's in the left. The spleen is in the right. Did he even feel it? No. Accidentally discovered. They were doing like this sonar and CT, and they told him, you know what, yes, there is a condition like this. I've seen that in the medical school. So it's a mirror imaged. Does that do anything? No. He didn't have any issues. Accidentally discovered. So that's telling us, did he feel like go to the doctor like my liver is in left side? No, he didn't even know because you don't have proprioceptors in any of the viscera. And the receptors responsible for the proprioceptions are called muscle spindles in the muscle, Golgi tendon in the tendon, and the name gave it away. It's not memorization. It's called muscle spindle. What do you think? In the muscles. It's called Golgi tendon in the tendon. And then once in the joint capsule, it's in the capsule, in the joint itself. So muscles, tendons, and capsule, the joint itself. Chemoreceptors. If you guys are following with me as we go now, you know that we have baroreceptors. Where is it? One in the aorta, and the other one is carotid. Exactly the same locations, exactly same locations. They have other types of receptors, but these ones are called chemoreceptors in the same spots. Okay, but you call it instead of, do you remember what did we call the other ones? We called it aortic sinus and carotid sinus for the pressure. This is called aortic body and carotid body. In the same spot? Yes, in the same spot. But what are you detecting? Chemistry of the blood, not the pressure of the blood. What do I mean by chemistry of the blood? Oxygen, carbon dioxide, and pH. This is what they detect. Are they doing the same job? Of course not. Chemistry. So here's what happened. Remember what I told you about the aortic sinus and the carotid sinus? When the pressure increase, the wall distends, send the signal to the brainstem, slow down to drop it. Same thing here, but in chemistry. So it detects the chemistry of the blood, specifically oxygen, carbon dioxide, and pH. So if the oxygen drops and carbon dioxide increase, think about it. Respiratory, yes. You're not breathing much. Make sense? Why are you breathing? To gain oxygen, get rid of carbon dioxide. Your oxygen drops. Carbon dioxide accumulated. Are you doing the work as it should be? No. So this will send the signal to the same spot, brainstem, and the brainstem will tell the respiratory system, breathe more. Same negative feedback. But I want you to specifically remember that even though both of them are called aortic and carotid, but sinus is not the same as body. You have to remember this. Okay? Aortic sinus, carotid sinus is for pressure, baroreceptors. Okay? Sinus for baro. Bodies for chemistry. Okay? So sinus is for baro. BS, whatever you want to call it, BS. Okay? Baro, sinus. Remember it somehow because both of them are called aortic and carotid. How do you know them from each other? And it's completely different. Okay? So baro are called sinuses. Baro means pressure. Is that clear? Baroreceptor, BS. You know what BS means, right? But just to remember. So BS, this is how I remember it. BS, baro sinus. Baro are sinus. Obviously, chemo are bodies. And this is what you need to know. Here are the chemoreceptors. If you noticed, it's in the same spot. But there are additional chemoreceptors in the hypothalamus. Is it detecting the same thing? Yes. Also detecting the chemistry, but it's an additional set. Is that the case for the sinuses? No, just for the chemoreceptors. So you have baroreceptors. Are we following? Baroreceptors, aortic sinus, carotid sinus. Chemoreceptors, aortic body, carotid body, plus central chemoreceptors in the hypothalamus. So you have two ways to detect the chemistry, but they detect same thing. But let me tell you this. Do you know the relationship between carbon dioxide and pH? Does anybody know the connection between those two? They are directly related. pH and carbon dioxide. What's the relationship? Like if carbon dioxide goes up, what? The what? Doesn't go up. Carbon dioxide is going to dissolve in the water. What does it make? Hydrogen ions. Yes, it's carbonic acid, which is hydrogen ions. So what's the pH? Goes up or down? Down. Did you get the relationship? Carbon dioxide goes up, pH goes down. This is how it works. Why? Because carbon dioxide goes up, dissolve in the water, making carbonic acid. Carbonic what? Acid. Acid. Right? So the pH goes down. That's it. This is for the chemistry part. Now, the sensory pathway. How do we talked about the receptors already, right? You have receptors everywhere, and you have a nerve that takes the sensation from these receptors and bring it up to the brain. What do you call those? Sensory or afferent? Yes, afferent, isn't it? Sensory or afferent. This afferent, it does not go from the receptors all the way to the brain. No, you have to go in 3 steps. Okay? You go from the receptor to the ganglia. This is called the first order neuron. And then you go from the ganglia into the central nervous system. And this is called the second order neuron. And the third one that goes to the thalamus. So you go like if the clinic is in the 3rd floor, you have to go 3 levels, right? You have to go 1, 2, 3. You can't jump, right? So you go from the receptors to the ganglia, from the ganglia to the central nervous system, spinal cord. From the spinal cord, you go up to the brain, the thalamus specifically. And then the thalamus can send it to the brain, to the cortex or not. But these are the steps. It's not one huge long nerve that take it from the receptor to the brain. No, we don't have such a thing. It has to go in these 3 orders: 1st order, 2nd order, and 3rd order. Okay. After the 3rd order, which end at the thalamus, would the thalamus send it to the brain or not? We talked about the functions of the thalamus before. Do you remember this? The secretary of the brain. It sorts out and filters out the sensations and allows some of them to go to your awareness, which is the cortex, and others are blocked. Do you remember that? The sharp pain and the prickling pain is allowed to go in. Anything sharp can go all the way to the cortex. You'll be aware of it. Anything that's less than that will be blocked, right? So does it go to the cortex or not? It depends. But it definitely go to the brain, specifically the thalamus. For the 2nd order neuron, they are going to cross and this is something that I want you to know. Meaning, I'm touching something. There is the first order neuron from here, from the receptors to the ganglia. Follow me. The second one will take it from the ganglia to the spinal cord or to the central nervous system, but it's going to cross. And then it will go to the opposite. So here goes to here. It cross. Second order neuron cross. If this is the receptors in my right hand, it go to the ganglia in the right side. And then the next one will take it from there and cross. And then when it goes up, it goes in the left side. And vice versa. If you're in the left, second order neuron need to cross. And we call that decussation. Decussation means crossing. So now you did first and you did second. Now you're going up or down the tracts. Let me tell you this. If you're going up, like you are in the spinal cord and going up, brain stem, and then you go to the brain, are you carrying sensation or are you carrying motor command? Sensation. So anything that goes up is carrying sensation. Anything that's going down is carrying motor command. Remember when I told you, you go to your manager to give him information, not orders, right? The manager give you orders, right? Well, who is the manager? The brain. So obviously, if you are in the spinal cord and going up to the brain stem, sensory. From the brain stem and going up to the brain, sensory. And if you're going down, it's motor. That's number one. Number two, this is something that you need to know. When I show you one of the pathways, you need to tell me right away, is that sensory or motor? And this is number one. Number two, how to know if it's ascending or descending. How to know? From the name. Spinothalamic. What does it mean? From the spinal cord to the thalamus. Is that going up or down? Up. The name gave it away. Spinocerebellar. Up or down? From your spinal cord to the cerebellum. You're going up or down? You're going up. Sensory. Posterior column, you don't know, but I will show you. It is going up. This is something that the name doesn't give it away, so just remember it. Posterior column, do you remember the columns? I think you remember the columns. Anterior and posterior and lateral. The posterior one is the third pathway. But the first two, I don't think you can miss it. It's called spinothalamic. It's called spinocerebellar. You're going up. You're carrying sensation. This is number two. Number three, what kind of sensation are you carrying? Tell me where are you going to, and I will tell you what kind of sensation. Example, spinocerebellar. Where is it going to? Cerebellum. What's the function of the cerebellum? BPM. Balance, position, muscle movement. So what do you think, what kind of sensation going to the cerebellum? Well, what's the cerebellum interested in? So these sensations that are carried are what the cerebellum is interested in, which is balance, pressure, and muscle movement. As simple as this, right? You're going to the cerebellum, but what kind of information do you need to do my function? Balance, pressure, and muscle movements. These are the sensations carried by the spinocerebellar. How about the spinothalamic? So look at this first. This is the posterior column, the blue, right? This is the lateral column, and this is the anterior column. We finished talking about the gray matter, the posterior horn, the anterior horn, lateral horn. We're talking about the white matter now. So this blue in the back here is the posterior column. The posterior column is two. One of them is called gracilis, and the other one is called cuneatus or cuneate. Gracilis and cuneate. You need to remember this. Gracilis and cuneate. These are the two within the posterior column. Now look at these. Look at the yellow. Spinocerebellar. What is it? Is it sensory or motor? Sensory. Going up or down, ascending or descending? Ascending. What kind of sensation? The sensation that cerebellum is interested in. BPM. Next one are the green, spinothalamic. You're going to the thalamus, carrying what sensation? What the thalamus is interested in, which is pain, pressure, right? Pain, pressure is the most important. This is what's carried in. So here is the spinothalamic. Spinothalamic, this is the third. Okay, so it will go to the thalamus, and what is it carrying? So in every one of those, we already talked about first and second order, right? First order from the receptor to the ganglia, that's it, nothing much to know. It's just the afferent that's carrying sensation from the receptors to the ganglia. Second, from the ganglia to the central nervous system, spinal cords, or sometimes it's the brainstem. In this case, it's cross. We talked about this. That's it, nothing much to know, just cross. Second order. So we're talking about the third now, the one that goes up or down. It's in this case we're talking about up because we're talking about sensations, right? Ascending. So what is carried here? And this is the bottom line that I want you to know. Are you ascending or descending? Does it mean it's sensory or motor? What kind of sensation? What kind of sensation? It goes without saying if you know the name, spinothalamic, what the thalamus interested in. Sensations like touch, pressure, and pain. Touch, pressure, this is in the anterior one, pain and temperature in the lateral one. Look at this again. Do you see this one in the front, the green? This is the anterior one. Look at this a little bit lateral here in the lateral column. This is the lateral spinothalamic. So we have two of them. Generally speaking, we're talking about touch, pressure, pain, and temperature. These are what the thalamus is interested in. This is something that needs to stop at the thalamus, and the thalamus will decide, should I allow it up or not? What is it? Crude touch, not the fine touch. Crude touch and pressure, this is in the anterior. Pain and temperature, this is in the lateral spinothalamic to be specific. So if you look here, this is the first order neuron, and it goes up to here, right? What is this? The ganglion. What is it called? The full name? Dorsal root ganglion. Yes. Now it goes in, you're done. The red. Look at the white, cross. And then look, it goes up, but always remember it's the opposite, right? It cross. So if you see here, these are the tracts. Obviously, it goes without saying, if I'm in the spinal cord, it's just all understanding. If I'm in the spinal cord here, and this is the brain, as I am going, I have to go through everything on my way, right? I'm going up, go through the medulla, go through the pons, go through the brainstem, right? Until I get to the thalamus. Now there is something that you need to know that's called referred pain. Simply, referred pain is a pain that you feel in another spot than the one that is injured or the one that's having a problem. The best example that I think we all know, if somebody's having heart attack, where the pain? Left pectoral region, left shoulder, left arm, in this area, right? Is there anything wrong here? Absolutely nothing. Where is the issue? In the heart, right? How did you feel it here? Simple explanation. I don't want to overwhelm you. Just understand the simple explanation, okay? Here's what's happening. The heart sensation goes same way, first order, second order. It goes in a specific pathway until it reach here, the cortex. What's the relationship between those parts right here? Yes, what's happening here is sensation from there follow almost the same. It's very close to each other. They go together like this. They follow the same pathway. So by the time they reach the cortex will be having hard time to distinguish. Like, I'm getting an issue from this. What is this? Either the heart or the shoulder, but the heart is here. Yes, not this is, I'm not talking about you knowing about it. I'm I'm talking about the cortex. By the time you reach the cortex, you go exactly the same thing. Okay? So it's hard to distinguish. So if that's the case, the cortex is confused, and the cortex will say, well, is that the heart or the left arm and left pectoral region? What do you think is more common to occur? Did you ever experience pain in your heart? Probably never, right? But do you experience pain here? Of course. So what do you think? If you are the cortex, would you think it's coming from the skin in this area or coming from the heart? Of course, you will say it's coming from the skin, right? Is that correct? Is that the location of the actual problem? No, it is not. And I always say it like this. If I feel or if I hear somebody like talking or interrupting the class, like those bunch of students that used to make uh, noise here, okay? So if I hear something here, right? And I don't know who is doing this. It's in this area. Yes, which one? I don't know. It's in this area. So I will say, John, stop talking. Is it really John? He's the one who most likely do the noise. So I'm assuming he is, right? So cortex will do the same thing. The cortex will say, there is a pain coming. I don't know, it's the heart or the left shoulder. Of course, it should be this. Same thing for a lot of things, but this is the most important example. Look how they go together. They follow. Oops. They follow the same pathway. Look at this. The heart and this red area here, they come together very close when they reach the cortex. Here is the liver and gallbladder. You actually feel it in the right shoulder. You don't have to know all of this. I'm just, you need to know the idea itself. Why? And just this one example. Heart, you feel it here. That's it. But just for your information, there is a lot. If a patient come to me and saying I have pain here in the skin, I'm not assuming that he's having a shoulder issue. I have to ask about like a patient coming, literally, a patient coming to me, I saying like, I have pain here. You know what I'm going to tell him? Beside, did you injure here? Did you get an issue here? Did something hit you? Whatever it is. And then the next question is, do you have any problems, digestion? Digestion, the issue is here. I know, but are you having any issues in digestion? When you eat fat, do you feel some pain or not? Because I wanted to know if this is referred pain coming from the liver and the gallbladder or not. It's referred pain, right? So I have to think about it. Otherwise, it's all these, and again, just understand the concept. How about the posterior column? Is that ascending or descending? Posterior column. Ascending. Is that sensory or motor? Is it ascending or descending first? Ascending. Is it sensory or motor? Sensory. Okay. We have two of those. Gracilis and cuneate. Gracilis and cuneate. I think you guys noticed by now that I don't go word by word. I'm telling you what you have to know. This is enough. So what's the difference in simple words? What's the difference between those two, gracilis and cuneatus? Gracilis will detect sensation in this area. So this is a person like this. This will be cuneatus, and this will be gracilis. The, out, the outer parts will be the gracilis, and the inner parts will be cuneatus. Okay, is that enough? Yes, it is enough. Okay, now what? Now it's not enough. It's not enough to say it's coming from somewhere here in that center. that's not enough, right? You have to know exactly where is it coming from. And this will get us to something called sensory homunculus. Homunculus is Greek for map. You have a map in your cortex. Look at this map. This part here is for the mouth. This part here is for the hand. This is for the trunk. This is for the lower limb. This is for the genitalia. Yes. So if it goes, if it's coming, let's say, from the hand, it will literally go to this part. Do you see this? If it stops here, automatically the cortex will say, this is coming from my hand. How did you know? Because it goes to this area, this part of the map. And just if you wanted to understand where did they get that from, they brought one of these frog in the laboratory, frogs or rabbits or something, and they are monitoring the brain and they touch here and they see which one is lightening. Okay, there's a light that goes like out of this area. Touch, it's coming, light's coming from here. Touch again, yeah, it's coming from here. So this area is for the hand. The same thing will be for the motor, and I will tell you how they do it, but this is what they did it. Touch, this area is lightening. So yes, this area is for the hand. Look at this area here for the fingers. If it comes here, your cortex will interpret it as it is going from the fingers. If it comes to this, it's in the lips, and so on. How did you know? Like touch, like this. Can you localize it? Of course, if you're closing your eyes and I touch anywhere, can you tell exactly where it is? Yes, because each one of those will go to area of the map that represent it. And this is how the body knows, and this is called sensory homunculus, the sensory map. Spinocerebellar, same thing. Is that sensory or motor? Is it ascending or descending? What do you think? It's ascending. Is it sensory or motor? Sensory. Where is it going to? Cerebellar. What is it carrying? BPM. Balance, position, and muscle movement. That's it. There are two of those tracts. One is anterior and the other one is posterior. But again, you should know what kind of sensation is carried in these two. There is somatic sensation, as I mentioned, and there are visceral sensation. Do you remember this? Somatic sensation coming from skin or muscles, right? This is somatic. If it is in the viscera, inside, heart, bladder, respiratory system, anything that's inside your trunk is called viscera. This is visceral pain, and this is visceral pain, and this is something else, because here, this is interoceptors. Do you remember interior and exterior? If you're monitoring outside, something outside of your body, we call that exteroceptors, the exterior receptors. If it's monitoring inside, it's the interoceptors. Okay? And this is not as much as the somatic ones, but most of it is the same thing. You can feel pain, pressure, temperature, and so on. Now, how do these sensations from the viscera, how does it reach the brain? Is it like a nerve, like going in a space like this? Like, no, it is not. It jump on something to be protected. Are you getting my idea? If this, let's say this is a heart, okay? Receptors in the heart, and then a nerve go from the heart, and it wanted to go all the way to the brain, all right? Does it just travel like this, like in a space? No. It finds something going to the brain, and it's ride it. It follow it. You're coming here. You're not coming walking. You find a bus or something, and you ride the bus, right? You find a bus coming to the college, and you go to that bus. That's coming here anyway. Why not? So what is our bus here? It is cranial nerves number 5, 7, 9, and 10. And you do need to remember this. 5, 7, 9, and 10. These are the 4 buses that take all the sensations from your viscera going to the brain. It's not like everyone go individually. No. You have 4 buses, follow one of them. 5, 7, 9, and 10. Do you guys remember the names? What's 5? No, vagus is 10. 5, trigeminal nerve. 7, you guys need to know this. Facial nerve. 9, glossopharyngeal. 10 is vagus. You do need to know this. You have to. And I told you guys that the table is good enough. You have to know the table. Okay? And the table is summarizing like 70 to 80 slides. So you can't go less than that. You have to know the table. So 5, 7, 9, and 10. If I ask you, how does it reach? It doesn't have to be literally like this, but whatever it means, it's 5, 7, 9, and 10 cranial nerves. Trigeminal, facial, glossopharyngeal, and vagus. Where does it go? It go to a nucleus in the medulla oblongata. If you guys studied this and you know the functions of each part of the brainstem, you should know that all these sensations and reflexes go to the medulla oblongata, specifically solitary nucleus. Solitary means like one. So the sensation will go to the solitary nucleus. Now the somatic motor. Remember how did we go up? First order, second order that cross, and the third order. Are we following? Now what about the other way? Like you're going down. This is a motor. Where do we start? Cortex. Does anybody know which part of the cortex, to be specific, do we start the motor commands? It's part of the cortex. Does anybody know? If you give a decision right now, I am going to move my right upper limb. Here it is. Where did I start the order, the motor command? From the cortex. Which part of the cortex? There is a gyrus, specific. What is the gyrus? We talked about this. Yes, precentral gyrus. That's called the primary motor area. And the name gave it away. Primary motor area. If you wanted to start a motor command, you start from this location. So this is where it starts. Does it go down in 3 steps, just like going up? No. Here we have only 2 steps. So if you're going up, 1, 2, 3. This is ascending. If you're going down, it's only 2. Upper motor, lower motor. That's it. Not 3 steps. Okay, so we have the upper motor and you have the lower motor. The upper motor is inside the central nervous system. And it starts from primary motor area and go down somewhere within the central nervous system. Lower motor neuron will take it from there to the organ, to the muscle. I think it's clear enough. Starting from the cortex. I have upper motor and lower motor. Upper motor starts from the cortex. Which part of the cortex? Primary motor area. And where do you end? Inside the central nervous system. It can be the brainstem, it can be the spinal cord. And then what? The lower motor will take it from there, from where the upper motor ended, and it will go to the muscles. And you only have 2. Okay? Now, what are the pathways? Do you remember the pathways going up? Spinothalamic, spinocerebellar, and posterior column. Do you remember those 3? How about the descending ones? Look at this. One of them is called corticospinal. What do you think? Ascending or descending? Descending. Why? What's cortico means? Cortico. Exactly. Cortex to the spinal cord. It's from the name. Cortico-spinal. From the cortex to the spinal cord. Is that ascending or descending? Descending. Is that motor or sensory? It's motor. So, and also we have the medial and the lateral pathways. If you look at this picture right here, this is the corticospinal right here. Those. Here is one lateral, the purple. and one anterior. These are the corticospinal. And then you have the lateral pathway, which is a red, and the medial pathway, which are these. You have three of those. The medial pathway is reticulospinal, tictospinal, vestibulospinal. Do you see that all of them end with spinal? It means it's descending, going to the spinal cord. Where does it start? Reticular. Tectum, which is the brain stem. Do you remember the tectum and tegmentum, the two parts of the brain, not the brain stem, the midbrain? And vestibulo is from the vestibule. So all of these are going down. Corticospinal, I'm not going into all the details. All what I want you to know here is it's called corticospinal, right? It starts from the cortex, which is wide. They come together like this and goes down to the spinal cord. So you see this going like this. It looks like a pyramid shape. So this is called the pyramidal system. You have to know this. Why did you call it pyramidal system? It looks like an upside down pyramid, like this. If you start from here and you go down like this, isn't this is an upside down pyramid? Pyramidal, corticospinal. It is the pyramidal system. And this is obviously the upper motor. Corticobulbar, from the cortex, and it goes to the medial and lateral pathways. Not the most important, but this is basically about the eye, jaw, neck, but it's okay as long as you know it's ascending or descending. Again, this is the motor, and it's called the pyramids. And there are two subtypes. One of them is lateral, and the other one is anterior. That's okay. And now to the motor homunculus. Do we remember the sensory homunculus? The map for sensation? Same thing for the motor ones. And how did we know? Here it is. Same thing. They brought a rabbit or a frog or something, and instead of touching here and see this area lightening, they touch this, they open the skull, and they touch this point, and the rabbit goes like this. Okay? Oh, so this is for the muscles of the hand. And then touch this, and he do like this. Oh, so this is for like the elbow and these muscles. They touch this area, and he's bending like this. Oh, this is abdominal muscles. Did you get the idea? So there is a map for the motor commands as well. Where is that map? In the cortex. And this is how they find it. Look at this. Doesn't it look like the other one? It is like the other one, but instead of sensation, it is a motor command. And exactly, touch this. That's exactly what they did. Touch this point, they feel the thumb moving like this. Touch, move. Okay, or they touch this point, and you go like this. So this is how they know this motor homunculus. Medial pathway and lateral pathway. The medial pathway is controlling the trunk and the proximal limbs, and the lateral pathway is controlling the outer ones. And where is my, okay, I'm sorry about that, but there is something that I mentioned, gracilis and cuneatus. It's actually same thing here, but it goes like this. Okay, it's actually gracilis is lower limb and cuneatus is the upper limb. Okay, this is for the medial and lateral pathways. This is the medial pathway, and this is the lateral pathway. Okay, so I take it back, and I'm telling you that cuneatus and gracilis are the upper limb and lower limb. Medial and lateral pathways for the motor is center is medial, and the other ones are lateral. Okay. So medial is watching the medial aspect of the body, or the middle part, the axial part. Lateral is at the periphery. It's giving motor commands to these parts. Medial pathway and lateral pathway. Okay, last part within, now we covered the cortex. Now we cover the white matter inside, right? Are we following so far? We cover the gray matter and the white inside. We have some collections of gray matter within that white. It's not like everything inside is 100% white. No, there are some collections inside the white. What are these collections? Basal nuclei. The basal nuclei. Basal nuclei are helping the cerebellum to do the job. Coordination and control over the muscular contraction. Basal nuclei, helpers with the cerebellum. Okay, they provide the basal coordination and feedback over the muscle contraction. But this was part of the cerebellum, BPM, right? Posture and muscle contraction. Yes, basal nuclei are helping in creating and coordinating these muscular contractions. Did you get this? The basal nuclei, collection of gray matter inside the white matter, it's nuclei, and this is controlling or coordinating and controlling the feedback over the muscular contractions. Here are the basal nuclei, providing a background pattern of the movement of the voluntary muscles. And this is good enough to know for the basal nuclei. Cerebellum, what are you, what's your function? We talked about it already. BPM, balance, position, muscle movement. But what I wanted to add here is, but did we get this part? Function of the cerebellum, BPM, balance, position, muscle movement. Clear? Basal nuclei are helping with the part that's muscular contraction. It's helping this part, setting the background pattern for the voluntary muscle contraction. I'm giving you the bottom line. It cannot be less than this. Okay? So, what else do we need to know beside those three functions of the cerebellum? What I want you to know is, if you are the cerebellum, what kind of information do you need to do your job? Okay? Think about it this way. I am the cerebellum. What's my function? Balance, pressure, and muscle movements. Yes. How can I do this job? Well, I'm not going to do my job before you give me enough information. What kind of information do you need? You give me information from the joints, right? Think about it. You are responsible for balance and posture and muscle movement. What kind of information do you know? Do you need to do your job? Well, number one, give me an idea about my joints, position of the joints to be able to do the job, right? If you don't know, how can you do the balance? If you don't even know, like, if your joints are contracting or relaxing, flexing or distending, or, right? How can you do your job? So give me an idea about the joints and the muscle status. What is that? Proprioception. You need to give me the proprioception. Send it to me so I can do my job, right? What else do you need? Give me an idea from the eye. Isn't it different to keep your balance and position if you open your eyes versus if you close it? If you close your eyes and move, do you keep this exact same balance as you're opening your eyes? No, because you get extra information from the eye to help you do the three functions. Number three, remember when we talked about the glossopharyngeal nerve? And I'm sorry, vestibulocochlear, do you remember this? Vestibule and cochlea. Do you remember the vestibule responsible for what? What's vestibulocochlear? One of the cranial nerves that you're supposed to know. The cochlear is for the ears, and the vestibular is equilibrium or balance. And what's your function, cerebellum? Balance. So you need to give me information from the vestibulocochlear nerve, the vestibular part specifically. Is there anything that doesn't make sense here? I think it makes sense, isn't it? Makes sense. How to do my job, give me all these informations, right? So this is what I wanted you to know about the cerebellum. You have to get information from the eye, from the vestibule, from the proprioceptors. That's it.